All right, so, and Dr. Conte, I think you can go ahead. It's now recording.
Okay, so good evening, our chiefs, colleagues. Welcome to another week of discussions in this forum. So today we're discussing a very important topic, aortic valve disease. And we have Dr. Maduka to take us through this discussion. So after the presentation, we'll open the floor for questions and comments, first from the participant and then our chiefs. So Dr. Maduka, if you're ready, the floor is yours. Thank you.
All right, thank you very much. Good evening, my teachers. Good evening, respected colleagues present. Today we'll be taking aortic valve disease. I want to especially appreciate Dr. Ibrahim Itubi, whose slides were very helpful in making this presentation today. I hope I can be heard clearly.
Yes, please, we can hear you.
Right, so I'll follow these outlines. I'll try to be as fast as possible. I hope I'll finish this in 1 hour. So a bit of embryology. The cardiac valves develop from the mesodermal germ layer, usually between the 4th to 7th week of gestation. And so any other thing or any factors that affect embryogenesis during this will affect the development of the valves. So the aortic valve centerpiece and like ventricle aorta, and the tricuspid valve is located inferiorly and to the right of the aortic valve, and both valves are boxed on the posterior inferior margin of the aortic root. The aortic valve normally should have 3 cups. There's a right and left cups, and then there's the non-coronary cup, also known as the posterior cup, being slightly larger than the 2/3 in 2/3 of individual. However, it's said to have no clinical significance. So the aortic valve, guards is a kind of, I will use the word, kind of demarcation between the left ventricle and the aorta. Normally, it should have 3 cups, like I said, but there are various variants. There's the unicuspid, the bicuspid, quadricuspid, cuspid, and it could also be fenestrated. Usually opens on systole, and the normal area should be between 3 to 4 cm squared. The aortic valve disease is recognized by finding a heart murmur. Thus, this highlights the importance of clinical examination in every patient. The murmur can be first detected in an asymptomatic patient, example, a young athlete, or a routine physical examination. The aortic valve affected by rheumatic heart disease, in general, diastolic murmurs are never innocent. The most appropriate unique investigation is almost always the echocardiogram. So abnormal valve function could be stenostic, it could be regurgitant, and usually a single valve can have both stenosis and regurgitation, but both lesions are said never to be severe at the same time. So coexisting valve lesions, when you have aortic stenosis and mitral regurgitation, could be from a single disease process. It could be from different disease processes. One valve lesion may also be a cause of another. So this is a picture of different ways we can view the aortic stenosis. The first at the upper part, my left hand side, is looks like there are only two valves. So you could say that could pass for a bicuspid valve. The one inferiorly is rhomatic in appearance, while the one on my right side is degenerative. More of, you find it more in elderly people. So the aortic valve is characterized by thickening and reduced, results in restriction of blood flow from the left ventricle to the aorta, causing secondary left ventricular hypertrophy. 3 common causes of aortic stenosis are recognized. It could be congenital, it could be rheumatic, it could be degenerative. Patients usually present around the 7th decade of life. Overall, it is most common form of valvular heart disease in the Western world. Rheumatic fever can affect the aortic valve also. So the risk factor of aortic stenosis could range from sclerosis, atherosclerotic changes, hypertension, advanced age, smoking, abnormalities. Also, some syndromes such as the Williams syndrome. So the pathophysiology of aortic stenosis is such that when the aortic valve is stenosed, is narrowed, so there is a kind of difficulty ejecting blood from the left ventricle to the aorta. And so there's this kind of pressure gradient that develops. Eventually the left ventricle end diastolic pressure rises, which causes a corresponding increase in the pulmonary system. And so could result in the long run to difficulty in breathing due to increased hydrostatic pressure that occurs around that area, seeping fluid into the lung or alveoli parenchyma. So the patient may present, dyspnea. And so this increased left ventricular end diastolic pressure that rises, that gives rise to increase in pulmonary pressures, lead eventually to diastolic dysfunction. And also, when a patient has aortic stenosis, by way of adjusting to this condition, we are aware that the left ventricular mass, increases. And so this left ventricular mass that increases also contributes to the diastolic dysfunction that we all see. So the left ventricular mass that is increased corresponding to or with the increased left ventricular systolic pressure that occurs, as well as the prolonged systolic ejection phase, will also lead to increased myocardial oxygen requirements. So these things I've mentioned also can lead to systolic dysfunction. So the systolic dysfunction and diastolic dysfunction that occurs will ultimately lead to development of heart failure. So the diagnosis of aortic stenosis, we have to, go through the clinical history, examine this patient, and some investigations will also be required. So aortic stenosis could largely be asymptomatic. However, in a patient that has a bicuspid aortic valve, symptoms could develop between the 5th to 6th decade, while the senile aortic stenosis, which could also be known as the degenerative aortic stenosis, symptoms will usually develop between the 7th to 8th decade. The symptoms classically include angina. A patient could present dyspnea, that is in failure, and there could also be syncope. And death can also occur. And it's also important to note that patients with aortic stenosis could develop what is known as the high syndrome, which is, aortic stenosis, the patient with aortic stenosis having GI bleeding, and this GI bleeding results from angiodysplasia, that we notice within the GI tract, as well as the dysfunction of the von Willebrand factor in patients with aortic stenosis. So the history is important. In elderly patients, it could likely be degenerative. middle-aged patient will consider rheumatic or congenital causes, while rarely in young people, you could say it is they could present, their presentation will be with the unicuspid valve. And the congenital aortic stenosis usually develops symptoms, less than 60, people less than 60 years. That's when they will develop their symptoms. People, the patients with bicuspid aortic valve text will say, while in rheumatic, the presentation will be greater than at the 60th decade of life or greater for both rheumatic and degenerative aortic stenosis. The cardinal manifestations of acquired aortic stenosis are dyspnea, angina, syncope, and ultimately they could develop heart failure. So there could be gradual decrease in exercise tolerance, fatigue, or dyspnea on exertion. The left ventricular diastolic dysfunction leads to rise in end diastolic pressure, leading to pulmonary congestion. This is what I tried to talk about in the pathophysiology. For the angina, usually systolic end diastolic pressure causes a form of wall stress, okay, causing compromised blood supply to the endocardium. And so they could present with chest pain. The other modalities or other ways or other things that can also lead to angina in them, which we'll talk about as this presentation goes on. So the syncope they usually develop could be exertional or it could be at rest. Mostly the exertional syncope that happens, we understand that they have narrowed outflow. That is, the aortic valve is, the aortic outflow is stenosed, or limited aortic valve is stenosed. So the amount of blood that can be pumped is fixed. So it cannot be varied when there is exercise. For instance, during exercise, the beta-2 receptors are stimulated, leading to vasodilation. So ideally, in a normal person, there should be corresponding increase in ejection of blood. This does not happen. And so usually when they have this exertion, because of fixed forward stroke that happens in them, regardless of vasodilation that takes place during exercise, there's reduced perfusion of blood to the brain, and then they could present with syncope. Largely for patients having syncope at rest, the mechanism behind theirs is usually arrhythmias that lead to that. So the GI bleeding, like I talked about, they could have head syndrome, which essentially they have angiodysplasia in setting of aortic stenosis, and usually arises from shear stress induced platelet aggregation with a reduction in high molecular weight multimers of von Willebrand factor. So they have a form of acquired von Willebrand disease in them. So these lead to a syndrome that is known as the Head syndrome. Patients may present with manifestation of infective endocarditis. They could come down with stroke, and calcific aortic stenosis rarely may cause embolization of calcium to the heart or the kidneys. Physical examination is important in these patients. Check the pulse. You can see the pulsus parvus ectadus, known as the slow rising, leaking, or low amplitude carotid pulsation. And they could also have the carotid shudder or palpable thrill in them. Further, late peaking of ejection systolic murmur. Some texts say mid-systolic ejection murmur is also noted, also described as a crescendo, decrescendo murmur. And prominent high-frequency bounds may radiate to the apex. Prominent high-frequency components may radiate to the apex the so-called Galavadin murmur. So usually the patients with aortic stenosis usually hear the murmur at the second left intercostal space at the upper part of the chest. And we expect radiation, along the lines of the carotid artery. However, in some patients, you find out that the murmur radiates to the apex of the heart. So being mistaken for murmur of mitral regurgitation. So that is the Galavadin's phenomenon. So they could have splitting of S2. We recall that they usually have prolonged systolic ejection phase. And so this prolonged systolic ejection phase could cause the closure of the aortic valve to be delayed and then coincides with the P2 sound, or even comes after the P2 sound. And so that is what leads to the splitting of the S2. So it could, like I said, it could be prolonged such that it coincides with the P2, in which the sound will become single, okay? Or it could come after the closure of the pulmonic valve. And so you have what is called a reverse or paradoxical split of S2. So they could also have the dynamic auscultation, where the intensity of the systolic murmur varies from beat to beat when the duration of diastolic filling varies, as in atrial fibrillation or after a PVC. The murmur of valvular aortic stenosis is usually augmented by spotting, which occurs because of the increased stroke volume that happens when one assumes this position. And it is reduced in intensity by reduced transvalvular flow, which will come from standing or the strain phase of valsalva maneuver. So this is what I tried to explain when I talked about the paradoxical split. Okay, so usually the aortic valve will close first. Okay, the sound, we'll hear the sound, the S2 sound, there are two of them. So there's the A2 and the P2. So the A2 typically will close first, followed by the P2. But when a patient has aortic stenosis, especially when it becomes really severe, okay, the prolonged systolic ejection phase will cause a kind of delay in closure of the aortic valve. And so you find out that the aortic valve could close at the same time where the pulmonary valve is closing. So you hear a single sound, or it could close a bit after the closure of the P2. So that's where you know. So the echocardiography findings, echocardiography is important in evaluating a patient with aortic stenosis. So we'll be looking at the Doppler echocardiography, where you look at the transaortic depth velocity. You're looking at the transaortic pressure gradient. The aortic valve area could also be evaluated using the continuity equation. And then you also want to look at possibility of coexisting aortic regurgitation or mitral regurgitation, as well as the sizes of the chambers, involved. So these are the things we'll look out for when we are using echocardiography to evaluate a patient with aortic stenosis. So using these variables, you could see, you will find out we can grade aortic stenosis into mild, moderate, and severe. So the valve area, if it's less than 1, or the gradient, having a gradient greater than 40, or a transaortic jet greater than 4, okay, 4 meters per second, excuse me. So these are parameters you can use to say that the patient has severe aortic stenosis. The other values which correlates with the degree of stenosis are shown. For instance, if the valve area is greater than 1.5, okay, or the gradient less than 25 millimeters mercury, or the Doppler jet of less than 3 meters per second. So we could infer that the patient is having a mild aortic stenosis. So using this 2014 American Heart, this 2014 American Heart Association staging of aortic stenosis, where you have stage A to D. So the stage A essentially is said to be people at risk of aortic stenosis. However, the valves may appear, you could see things, the valve at this point is not stenosed, however, but you could see things that pose as a risk to development of aortic stenosis, such as having a bicuspid aortic valve. Usually, the aortic valve hemodynamics, you find out that the aortic velocity, okay, will be normal. That is less than 2 meters per second, and there will be no hemodynamic consequences or symptoms. So you say these people could be at risk of aortic stenosis. For people in stage B, the progressive aortic stenosis, they could have mild to moderate hemodynamic changes that suggest aortic stenosis. For instance, for moderate, they could have the aortic velocity. The velocity across the aortic valve could be between 3 to 3.9 meters per second, which is moderate. Okay, so in addition to this, you find some mild to moderate or moderate changes in the valve, either rheumatic or degenerative, or even a congenital abnormality of the valve, okay, that will also coexist with these valve hemodynamics I just mentioned. And usually the consequences of these consequences we find in this progressive aortic stenosis is just that you may just find early left ventricular diastolic dysfunction in them. And of course, they will have no symptoms. So the C is the symptomatic severe aortic stenosis. Sorry, the asymptomatic severe aortic stenosis. So the C can be grouped into C1 and C2. Basically, the two are the same. They do not have symptoms of aortic stenosis, and the valve hemodynamics you find out or you discover are those suggestive of severe aortic stenosis. However, for the C2, it is found, you find out that the ejection fraction is reduced. So that's the difference between the C1 and C2 when you're looking at a patient that has asymptomatic severe aortic stenosis. So for the D, people that have severe aortic stenosis and have symptoms. Okay, so D is divided into D1, D2, and D3. For the D1, they have severe symptomatic aortic stenosis with high gradient. Okay, so you have features the one. You have the aortic valve velocity, the velocity across the valve greater than 4 meters per second, greater than or equal to 4 meters per second. And you also have a gradient greater than or equal to 40 millimeters mercury. Of course, you also have features, okay, when you look at the valve that suggest severe leaflet calcification. And the same thing. However, they have low flow and low gradient. So what this means is that although the valve area is less than 1, which suggests severe aortic stenosis, so it will not appear severe. Both the velocity across the valve and the gradient across the valve will not be up to the values you have for severe. So you have a value less than 4 meters per second for the velocity across the valve, and the mean gradient across the valve will also be less than 40. Okay, so they will have angina, they could have syncope or presyncope. They could also present in heart failure. So for the D3, they are symptomatic and they have severe low gradient aortic stenosis with normal left ventricular ejection fraction. So essentially, you have features in D3 that are similar or the same, okay, with that in D2. So they have severe aortic stenosis when you assess it based on the area, okay, of the valve. So they will have the aortic valve area less than 1. However, the flow across the valve and the gradient will not be at the value that suggests very severe or severe aortic stenosis. So just like D2. However, the difference between the D2 and D3 is that whilst D2 has reduced left ventricular ejection fraction, the D3 is preserved. And so this classification is instructive because it helps us to know which patients will go for valve replacement, as we will see as we go ahead in the presentation. So management basically, if the patient is in heart failure, you manage the heart failure. If the patient has arrhythmia, you manage it using the guidelines. Then you could also employ balloon valvuloplasty in this patient, which provides modest hemodynamic effect and can provide short-term improvement in survival and quality of life. But these benefits are usually not sustained. The aortic valve replacement is the standard for treatment in a patient that meets the indication. And it could be surgical or it can be through the transcatheter aortic valve replacement. So we'll just have this in mind, the levels of evidence or the class of recommendation. So for the class of recommendation, like we all know, the class 1 conditions for which there is evidence and a general consensus that a given procedure or treatment is useful and effective. The class 2 conditions for which there is conflicting evidence and or a divergence of opinion about the usefulness and efficacy of a procedure or treatment. Okay, so the 2 is divided into 2A and B, where the weight of evidence, okay, in favor of the treatment to be given is more beneficial, while the 2B, the evidence or the usefulness or efficacy is less well established by the opinions that are given. So the class 3 is conditions for which there is evidence or a general agreement that the procedure of treatment is not useful or effective, and in some cases may be harmful. So looking at this, the summary of this table is that for patients, if you recall the staging A to D, okay, the summary is just that patients with stage C, 2, and D, okay, have stage C2 and D have class 1 evidence of aortic valve replacement. So for instance, a patient that have symptoms due to aortic stenosis with high gradient and high flow, okay, which falls into D1, will benefit from aortic valve replacement. That's the level 1 evidence. So when you carefully look at this, which we can do in our spare time, you'll find out that those with C2 and D, okay, will benefit from the level of evidence is, class 1, okay, for aortic valve replacement. And so when you make up your mind to replace the valve, you will now want to evaluate the surgical risk in these patients. So if the risk is low, of course, you go ahead with surgical replacement. If it's prohibitive, if it's prohibitive, you want to consider if the the patient can be a candidate for transcatheter aortic valve replacement, okay, with expected benefit. If that is true, you go ahead with the transcatheter aortic valve replacement. If the surgical risk is high, you could choose either going ahead with the surgery or doing a transcatheter aortic valve replacement, depending on the presentation of the patient. Now, the differential diagnosis of aortic stenosis, could be suggestive based on if the patient has, if you're picking a systolic murmur, so the patient could be having problem from the mitral valve, could have hypertrophic cardiomyopathy. If you're thinking of an atherosclerotic lesion, for instance, the patient presenting in syncope, so you want to find out whether this patient has aortic stenosis from posterior circulation stroke. And then the differential diagnosis also could be based on if the lesion the patient has is supravalvular, in which you consider the Williams syndrome, in which a person has supravalvular stenosis, hypercalcemia, and metal retardation. The other differentials could range from subvalvular aortic stenosis or hypertrophic cardiomyopathy. So the patient with left ventricular failure, patients with severe aortic stenosis having an apparent moderate transaortic peak velocity and mean pressure gradient associated with a small effective aortic area. Aortic valve replacement will relieve afterload and may allow the left ventricular ejection fraction to increase towards normal. So when you look at a patient with low flow, low gradient in setting of severe aortic stenosis, especially when they are symptomatic, so it's good to determine whether the patient has a true aortic stenosis or a false or pseudo-severe aortic stenosis. So you offer the patient dobutamine stress echocardiography, in which you want to, you expect an increase in stroke volume by 20%. So you watch out for the valve area. If the valve area remains less than 1, while the gradient and flow across the valve increases to the severe range, so it could suggest that, yes, this patient has true severe aortic stenosis. So this is the protocol to use when you're considering doing a low-dose dopamine protocol for these patients. So usually the dose of dopamine is 2.5 to 5, and you're supposed to increase the dose, okay, every 3 to 5 minutes, maximum of 20 microgram per kg per minute. And so you stop the infusion when you have a maximum dopamine dose. You reach the maximum dose of 20 microgram per kg, or there's a positive result, or the heart rate rises 10 to 20 beats per minute over baseline, or exceeds 100 beats per minute, or the patient develops symptoms or a fall in blood pressure. So the things you see that suggest a positive result are as seen. So we can look at it in our spare time. So this is just what I've also talked about, how you determine if a patient has low flow, low gradient, severe symptomatic aortic stenosis, how you go about to determine if the patient has true severe aortic stenosis. So the definitive treatment, definitive management requires mechanical intervention. No drug reverses aortic stenosis, like you all know. So we prescribe appropriate medical therapy for associated risk factors in these patients, which could range from diabetes mellitus to atrial fibrillation. Then the surgical aortic valve replacement, usually traditional, definitive, and is time-tested therapy. Full stenotomy is the most common approach, even though people are beginning to use the partial stenotomy or mini thoracotomy approach, and surgical mortality is usually less than 3%. The transvalvular aortic valve replacement became available in 2011. It's being said currently to be equal or superior to surgical aortic valve replacement in high risk and intermediate risk patients. Well suited for patients with advanced age, extracardiac comorbidity, or anatomical factors that will complicate flow chart, if I put it that way, that helps you determine whether you go for a transcatheter aortic valve replacement or surgical valve replacement. For example, if a patient has low surgical risk, you go for the surgical valve replacement. If the patient is young, you will choose surgical valve replacement. If the patient is elderly, okay, and probably frail, you may want to consider a transaortic valve replacement. So this is also an algorithm that also helps us to choose what to use. For instance, if you're going for, if you want to manage this patient, okay, and this patient has any other comorbidity that may warrant surgery, so it is said that you will be, it's better for you to go for the surgical valve replacement. What I mean is that, okay, you have a patient with severe aortic stenosis that you want to manage, and probably this patient has significant multivalve coronary artery disease that may require CABG. So it's better for history of aortic stenosis. Clinical trials targeting calcium metabolic pathways are ongoing. For surgical aortic valve replacement or transcatheter aortic valve should
Oh, I think we lost Dr. Maduka a bit. Let's just be patient for a few minutes till he gets back online.
Sorry for that. It's been raining cat and dogs here, so the network is bad. Can you hear me, please?
Yes, we can hear you now. Please slide.
Okay. Okay. So, uh, quickly, electric connection can be caused by either damage or
Please, let's be a bit patient with Dr. Maduka. He's experiencing problem with the network. Hello, Eugene. Can you please pause the recording? Eugene, please, you can recommence the recording.
Okay, so sorry about that. The etiologies of aortic regurgitation are numerous, as we can see, but worthy of note is that for acute aortic regurgitation, where you can reach from acute rheumatic fever to infective endocarditis, dissection of the aortic of the aorta, and you can also have ruptured sinus of valsalva aneurysm. Those that could cause chronic aortic regurgitation could range from syphilitic aortitis, even hypertension, vasculitides like Takayasu and the rest. So these are also other causes of aortic root disease. We can look at this later. So trying to grade aortic regurgitation, you could use the semi-quantitative or the semi-quantitative or the semi-quantitative or the quantitative method. So the quantitative methods include the regurgitant flow volume, regurgitant fraction, and effective regurgitant orifice. There is also the proximal isovelocity surface area, PISA, that can be used. This is a picture, echo picture that is showing aortic regurgitation, as you can see in the picture here. The classification of aortic regurgitation using trying to take note of the severity of aortic regurgitation based on, aortic regurgitation based on severity. So you can see the regurgitant fraction, the values there. Let's go straight to the severe. So you have a regurgitant fraction greater than 50%, or a jet width greater than 65, or the effective regurgitant orifice greater than 0.3. So these are suggestive of severe aortic regurgitation. So the stages of aortic regurgitation, just like I mentioned for the aortic stenosis, classified A, B, C, and D. So the A is those at risk of aortic regurgitation, usually no hemodynamic consequence or symptoms, and the patient may just have a bicuspid aortic valve. For the progressive, they could have mild to moderate calcifications. They will have values that are suggestive of mild to moderate aortic regurgitation. When you look at the effective regurgitant orifice, the regurgitant fraction, and regurgitant value, the values will be within that for mild to moderate. The patient will have normal left ventricular systolic function and will also have no symptom. For the C, which is the asymptomatic severe aortic regurgitation, they will have features on echo suggestive of severe aortic regurgitation. For those with C1, they will have a normal ejection fraction. For those in C2, the ejection fraction will usually be reduced. For the D, they are symptomatic and they they have severe aortic regurgitation. They have values on echo. When you look at the parameters I talked about that are suggestive of severe aortic regurgitation, and they will have symptoms ranging from exertional dyspnea to angina, could be reduced, or it could be in the mid-range region. So the pathophysiology of aortic regurgitation usually has to do with presence or absence of compliance of the left ventricular chamber. So in a situation where you have acute aortic regurgitation, there is usually no compliance because it's acute, and so there has been no time for the ventricle to adjust to the changes that have occurred, and so the patient develops elevated left ventricular end diastolic pressure, which transmits to the pulmonary areas, and the patient will come down with dyspnea. So similar thing is what we'll find in chronic aortic regurgitation, but in these patients, there is compliance. So it's something that takes a while, and within this time, the left ventricle dilates, okay, and then it can contain much more blood. Okay, so it's something that takes time to develop, even though at the end they will still develop the elevated left ventricular end diastolic pressure and could also come down with symptoms also. So the physical findings, they will usually have wide pulse pressure. The diastolic pressure could be 60 or lower than that. They will have diminished A2. And like I said, they have a lot of eponyms, So you could find the Demuset sign where the patient just nods the head. They could have the water hammer pulse, the Durosis and Traube sign, which are almost similar, just that for the Durosis, you hear the sound when you place your stethoscope over the femoral artery, okay, and then apply pressure. You hear a sound usually in diastole. You hear both is so the oxyphilic murmur is a murmur we hear as a result of the fluttering of the anterior leaflet of the mitral valve due to interference of regurgitant aortic flow, on the valve. We can go through spare time of the rest.
Hello, Eugene, if you can please pause the recording while we wait for Dr. Maduka to come back online. Okay, so let's restart the recording.
So,
thank you.
Okay, so quickly, the 2D echo, we are assessing for the aortic valve and the root, left ventricular function, left ventricular end systolic dimensions greater than 55 millimeter. That's what we are looking at. And the Doppler severity of regurgitant jet. So treatment of aortic regurgitation, if the patient is in failure, you manage accordingly. So you use your anti-failure regimen, antibiotics indicated in patients that have coexisting endocarditis. So surgical modality could range from the balloon aortic valvuloplasty to the Ross procedure or valve replacement. So this is what the Ross procedure entails. Simply means taking out the pulmonary valve and putting it in place of the aortic valve while you now use the homograft, okay, for the pulmonic position that you've removed its valve from. So that's basically what the Ross procedure is all about. So indication for replacement could range from increasing symptoms, enlarging heart and chest X-ray, infective endocarditis refractory to medical treatment. So the prognosis, chronic aortic regurgitation can be well tolerated for many years and is associated with a good prognosis. The 5-year survival is 75%, 10-year survival is 50%. The acute severe aortic regurgitation, however, is associated with high mortality from left ventricular failure. And early intervention is the key. So, like I also said for the aortic stenosis, when you go through this flow chart, okay, you will find out that the class 1 indication, okay, for aortic valve involve the stage 2, the stage C2, and the stage D. Okay, so that is just a summary of what this flow chart is talking about. For echocarditic regurgitation, if you look at the quantity effective regurgitant greater than 30, severe, if the regurgitant volume is greater than, if a patient has enlarged cardiac chambers, it can also suggest severe aortic regurgitation, in whom surgery is not ACEIs and dihydropyridine should be considered. Asymptomatic, moderate to severe pyridines have no proven recommended. In patients with Marfan syndrome, beta blockers remain the mainstay of medical management. So a few guidelines, okay, that is worthy of note. I'll just concentrate on the class 1 indications. Okay. The surgery is recommended in symptomatic patients, regardless of the left ventricular function, which is basically what I've said before. So you're looking at class, in the staging, you're looking at the class C2 and the D. Anything that falls within there, okay, surgery is recommended. Surgery is recommended in symptomatic and asymptomatic patients with severe aortic regurgitation undergoing CABG or surgery of the ascending aorta or another valve. So for these two, valve sparing aortic root replacement is recommended in young patients with aortic root dilatation if performed in experienced centers and durable results are expected. So this is also what I've talked about the flow chart, that helps you determine if a patient will have surgery or not. So a patient that has aortic regurgitation, patient is symptomatic, patient has left ventricular ejection fraction less than 50, okay, you should consider surgery in these patients. So if a patient has comorbidities, coronary artery disease, Coronary angiography is recommended before valve surgery in patients with severe valvular heart disease and any of the following. So if the patient has history of cardiovascular disease, patient has suspected myocardial ischemia, left ventricular systolic dysfunction in men greater than 40 years of age and postmenopausal women. Okay, so valve replacement is class 1. Right. So for stroke in patients with this condition, okay, if they can take orally for stroke patients in atrial fibrillation who are eligible for oral anticoagulants, NOACs are recommended in preference to the warfarin in patients with aortic stenosis, aortic and mitral regurgitation. However, in patients with severe or moderate mitral stenosis, what is usually recommended is warfarin. So these are my references. I want to also appreciate Dr. Itubi. Like I said earlier, his slides were helpful in doing this presentation. Thank you very much. I'll welcome questions and contributions at this point. Thank you.
Yes, thank you very much, Dr. Maduka, for a concise presentation. These are two very large topics that you've been able to compress and be able to present within 1 hour. Thank you so much. So I'll start with the comments. In terms of the complication of aortic stenosis, you mentioned an important point that with the calcified aortic stenosis, those calcium deposit on the valves can actually embolize and cause stroke. And that risk is even more when they go for surgery. Yeah, they can come out with complications of stroke, especially if the surgeons are not careful to be able to really handle the calcified valve when doing the replacement. Those calcium fragments can just break off and then get embolized, and the patient recover from the surgery with a stroke. So it's a very, very much feared complication, especially with the calcific, aortic stenosis. Some questions that I want to ask. Angina can be a presenting symptom for both aortic stenosis as well as aortic regurgitation. I want you to explain the mechanism of angina in each scenario. Then also, in terms of echocardiographic assessment in aortic stenosis, there is a value called the dimensionless index. I don't know if you've come across that. I want you to just talk about that. What are its advantages and how is it measured, and the reference values to say which the severity of the aortic stenosis. And then finally, for aortic stenosis, in catheterization, how would you by catheterization differentiate aortic stenosis from hypertrophic cardiomyopathy from catheterization? Yeah. Okay, so those are the 3 questions from me. Thank you.
All right, I'll start with the first. Differentiating angina occurs in both aortic stenosis and aortic regurgitation. So the difference in the mechanisms. Now, for aortic stenosis, okay, usually myocardial
Dr. Maduka's line is really problematic this evening. Now let's be patient.
Dr. Kunte, I think you can read what is in the chat room.
Oh, okay, as we wait. Okay. So, all right. Dr. Bai is saying excellent presentation. Dr. Itubi, thank you for a lucid presentation. Dr. Kalamama, thank you for extensive presentation. Pitamba is saying invasive and non-invasive ways of calculating aortic valve in aortic stenosis. Invasive is on right heart catheterization, Gorlin's equation, Haki equation, Agarwal Opara-Bao equation. That is all the invasive.
Hello?
Yes, Dr. Maduka, you are back. Okay, please.
Hello, sorry, can you hear me?
Yeah, we can hear you now. You can go ahead. I think he's gone off again. So these are very important points here being made by Dr. Dr. Maduka. All right. Hello, Dr. Maduka. We can't hear you at all. So what I would advise you do, stop sharing and then just use your audio, just talk so that at least you require less data to just talk. So stop, don't try to share your screen again. Just talk when you're able to get back online. All right. Yes, I'll go over the points made by Dr. Mba again. Say invasive and non-invasive ways of calculating aortic valve in aortic stenosis, calculating aortic valve area in aortic stenosis. So the invasive is on right heart catheterization, and the equations that you can use include the Gorlin's equation, Haki equation, and then the Agarwal Opara-Bao equation. And then for the non-invasive is by echo. So the continuity equation and planimetry to calculate aortic valve area. Thank you very much, Dr. Mba, for those comments. Then Peter Ba is also saying beta blockers are contraindicated in severe aortic regurgitation. Okay, so in mixed disease, will you have a continuous murmur or separate murmur? I hope Dr. Maduka will be able to respond to that. Dr. Mohammed is saying, thank you for a wonderful presentation. Dr. Ozor is saying, thank you very much, Dr. Maduka, for the awesome and ecstatic presentation. I think echo findings on aortic valve area also determine the extent of follow-up. Also, progressive aortic stenosis is defined by a reduction in aortic valve area by 0.03 centimeters squared per year. There is also the Bingham effect on aortic stenosis, in which there is prominent waves without elevation in the JVP as a result of the ventricular hypertrophy impairing effective atrial emptying. Please, could you explain the pressure recovery phenomenon and energy loss gradient in aortic stenosis? Thanks a lot. Okay, so the pressure recovery phenomenon and energy loss gradient in aortic stenosis. Okay, those are the comments in the chat box. Let me see if Dr. Maduka is on. Back on. Not yet. Okay. Okay, are there any more comments from all the participants? We can be taking more comments as we wait for Dr. Maduka. Okay, there are no comments for the time being. Probably we can take some exams experience from our colleagues. Dr. Itubi, Dr. Cyril, don't know if you have any comments to make about important things to look out for as far as the exam is concerned. Hello, Dr. Itubi.
Sorry, I was far from my.
Okay.
Good evening.
Good evening, Dr. Itubi. Thank you very much.
For the, I think what we pay attention to the one, the information on the aortic stenosis and the coach is very broad. So we need to go through the slides again and find a way to call it some things. But
Dr. Itubi, we're not getting you clearly.
okay. Sorry. Sorry, is it better now?
Yes, please. Yes, please.
Really, yeah. So the aortic stenosis and regurgitation are quite broad. And then there are newer things that are even coming up in it. But a few things I think we should pay attention to is one, going through the slides all over again, and then looking at the classical triad of symptoms that I have in aortic stenosis, the angina, heart failure, and then syncope. To be good to recall when patients have this, when they do occur, and then the duration they have, okay, from symptom to mortality, like angina, which is 5 years, heart failure, 1 to 2 years, and then syncope, 2 to 3 years. I remember Andrew gave us a code, ASD. So it's angina, 5 years. The S is syncope, 2 to 3 years, and then dyspnea, which is 2 years. So we should recall that. And then the aspect of the Heide syndrome, which is a multi-systemic disorder that is characterized by a triad. So Heide syndrome has a triad, which is aortic stenosis, GI bleeding, and then the acquired von Willebrand syndrome. Then we should also bear in mind the components of the Williams syndrome, which Maduka talked about earlier. And then the Ross procedure too, I've seen it in one MCQ previously. Then I think last week we did something on isolated aortic regurgitation. So as we look at the etiologies generally of aortic regurgitation, I remember there was one question that I think the answer was osteogenesis imperfecta, something like that, from one of Prof's questions. Then generally, that's what I would say. But for general practice, it's important to recall that there are guidelines as to how there are recommendations as to how the data recording and measurements should take place, especially if we are doing quantification for aortic stenosis. There are guidelines that show even the LVOT diameter, how it should be measured in parasternal long axis, how it should be zoomed, and then adjusting again. There are guidelines that show how all these measurements should be taken. But what is most important is to look at the classification again. And I like the way he simplified the classification, because that would also help us to know which patients will require and what intervention. So you look at the valve morphology on echocardiography if you're suspecting aortic stenosis, and then you do all your gradients, you check the gradients and then the pressure to look at which is low and high gradient. And by the time we do that, we now index it with the aortic valve area, and then look as well at their ejection fraction. A very important aspect I must not fail to mention is that aspect of distinguishing between pseudo and severe aortic stenosis, pseudo-severe aortic stenosis and the true aortic stenosis, because you can have an increase in the valve area more than one that is suggestive of less than one that is suggestive of severe, which may not actually be severe. So, and that's where the low dose dobutamine stress, which he mentioned, comes to play. So if you give the dose of the dobutamine, about 2.5 to 5 is titrated upwards, and by the time you give the infusion of that, you check for a positive result. And what will be a positive result is usually when you have an increase in the aortic valve area more than 1.0, okay? And if you have an increase in that, and then you look at the stenosis as well, look at the jets, whether it is greater than or equal to 4 meters per second, and then the mean gradient as well. So that helps to kind of differentiate between if you are looking at the pseudo-severe or the actual severe. Those are my comments. Then lastly, for the aortic regurgitation, we know it's a disease of several eponyms. So we also need to find a way of coding a number of those eponyms. Thank you.
Thank you very much, Dr. Itubi, for those comments. Interestingly, while you were talking, Dr. Maduka was online. He's back on. He went off a bit. Okay, Dr. Maduka, please, you have the floor. You can go ahead.
I'm sincerely sorry for this embarrassment. So
you understand. It's not your fault.
The questions you asked me, the angina that occurs is being talked about, so that I don't continue to delay us.
No, so you can go ahead. We are just taking other comments. Yes.
So angina in aortic stenosis. Okay, I was saying that the myocardial perfusion is usually compromised in them, okay, by reduced diastolic transmyocardial perfusion gradients that occurs primarily due to elevated left ventricular end diastolic pressure. So usually this pressure, when it's elevated, like we all know, causes a kind of compromise on the endocardial blood vessels, causing ischemia. This is one of the ways. But what I remember for the aortic regurgitation is that you recall that they have very wide pulse pressure. And so the diastolic pressure is usually low, very, very low. And it is in diastole that the heart muscles are perfused. So because of how low the diastolic pressure is, perfusion of those vessels, is kind of impaired, okay, causing the angina-like pain in them. So I don't know if there are any other additions to this. I will sincerely appreciate that. Then for the how to differentiate the please, can I still be heard?
Yeah, yes, go ahead.
Hello. Okay. To differentiate aortic stenosis, okay, when you do the cath lab, I record something like that. Usually you introduce a kind of PVC, okay, and is introduced, it usually confuses me. So so that
Wow. Samaduka, your line is really bad. We can't hear you anymore.
if I could get clarifications. So you introduce that PVC, pulse pressure is increased. Appreciate corrections.
Oh, hello. Okay. Just to comment on the points you just made. So about the mechanisms of angina in aortic stenosis. So apart from the reduction in blood flow because of the thickened myocardium causing compression of the coronary vessels, there is also increased demand, because you remember that in aortic stenosis, the heart is working against an obstructed LVOT, so the muscles hypertrophy and contraction increases. So there is increased myocardial work, as well as reduced perfusion to compression of the coronary vessel because of improper relaxation of the ventricle.
I think you people can continue, so I don't continue to delay us. My network is
Yeah, we understand. Okay, thank you.
very bad, very, very bad. I've switched.
Okay. All right. Then, and then for the aortic regurgitation, like you mentioned, so when you have severe regurgitation, aortic regurgitation, in fact, there are sometimes you can't even record the diastolic pressure. You'll see if you are using an aneroid sphygmomanometer, you keep getting a beat until you are reducing the pressure to 0. So once you cannot get a diastolic pressure, then you don't get any coronary perfusion. Okay? Because for your normal coronary perfusion, you need a competent aortic valve and the elastic recoil of the aorta that now perfuse blood through the coronaries. So when you have a very incompetent aortic valve and the diastolic pressure goes very low, it reduces significantly the coronary perfusion. So you can get angina. So both in aortic stenosis and aortic regurgitation, you get angina, but different mechanisms involved. All right. And then the other question I asked, I will just comment on the questions that I asked, so then we can talk about the other questions on the chat box. I asked about the dimensionless index on echocardiography. It's a very important index that is used to assess the severity of aortic stenosis. Okay, and it is important, especially, you know, when you have patients that you're not able to accurately measure the aortic valve area with planimetry, especially because, you know, for those patients, elderly patients who have calcific aortic valve, because of the excessive calcium on the valve, it can sometimes be difficult to measure the aortic valve area in planimetry and say for sure the severity of the aortic stenosis. So sometimes you can actually overestimate because the calcium deposits just sort of obscure the whole area, you have anywhere to measure. So the dimensionless index, you just measure the LVOT VTI, okay, velocity time integral, divided by the aortic valve VTI. Okay, that is the dimensionless index, the LVOT VTI divided by the aortic valve VTI. Now, when that value is greater than 0.5, it tells you that there is mild aortic stenosis. When the value is between 0.25 to 0.5, there is moderate aortic stenosis. And when the value is less than 0.5, then there is, 0.25, there is severe aortic stenosis. Another advantage of this also, compared to the continuity equation, is that for the dimensionless index, you don't have to measure LVOT area. And when you are using a continuity equation, the LVOT area measurement is the source of error most times, because that value is usually squared in the calculation. And so if you have any small change in your LVOT diameter, it causes an exponential increase in the LVOT area. So it's a big source of error when you are measuring. And as it to be mentioned, there are several guidelines as to what you can do to reduce that error. So, but when you are using the dimensionless index, you avoid using the LVOT area, and you just use the VTI of the LVOT to the aortic area, and it can give you an accurate measurement of this assessment of the severity. So it will not measure the area, it won't tell you the area, it will just tell you the severity of the stenosis based on those cutoffs. All right. Then the other thing was on catheterization, differentiating between aortic stenosis and dynamic LVOT obstruction or hypertrophic cardiomyopathy. So this one, you have to do, okay, left heart catheterization. So you put a catheter in the left ventricle and in the aorta, and then you measure the pressure simultaneously. Okay. So normally in normal people, when there is no stenosis, no LVOT obstruction, you know, the way the aortic valve are structured, when they open, they go into, they sort of fall into the sinuses, the aortic sinuses, so that you have, you maintain the L from the LVOT right down to the aorta. The diameter is maintained and there is no obstruction of the blood flow. The valves, when they open, they give way completely to blood flow. So the pressure, the left ventricular pressure and the aortic pressure in normal people in systole are usually the same. So when you look at those plots that shows you the cardiac cycle, you know, when you look at the pressure waveforms, so you'll see that in systole, the left ventricular wave is superimposed on the aortic, the wave of the aorta, the pressure wave of the aorta. Because in systole, when the valves open very well, blood flow is not impeded at all. So the pressure in the ventricle is transmitted into the aorta without any attenuation of the pressure, okay? So now when you have aortic stenosis, okay? So aortic stenosis, valvular aortic stenosis is actually a fixed, LVOT obstruction. When that happens, there is always a lower aortic pressure compared to the left ventricular pressure. So when you look at the waveform in systole, the LV, the left ventricular pressure will go higher and the aortic pressure will lag. Okay. Now, so in dynamic LVOT obstruction also, if you are looking at a normal rhythm, okay, you will see that the aortic pressure would also be lower than the ventricular pressure when you plot them together. Now, where the difference comes in is when you have, when you induce a premature ventricular contraction, okay, in the cath lab, you induce a premature ventricular contraction that comes early than the time you're expecting the next heartbeat to come. So in the fixed LVOT obstruction, the same relationship, the same difference between the LVOT pressure and, between the aortic pressure and the ventricular pressure will be maintained. So if you are looking at the graph, you will see that the whole graph will move downwards when you have an ectopic beat. So the amount of left ventricular pressure that is generated will be lower than what is generated in the normal beat, and also the LVOT, the aortic pressure will also be low, but the difference between them will be maintained. Okay, the difference will be maintained. Whereas in dynamic LVOT obstruction, when you have an ectopic beat coming, the left ventricular pressure will reduce slightly, but then the pressure in the aorta will reduce more, and then you will see a widening of the difference. There will be an increase in the difference between the left ventricular pressure and the LVOT, and the aortic pressure. Okay, so the difference between them will widen when you have a premature beat coming in. Okay, and that is what is referred to as the Braunwald's phenomenon. Okay, well, when you induce an ectopic beat, the aortic pressure falls way more compared to the LVOT pressure. So that's how you differentiate between the two in between aortic fixed aortic stenosis and LVOT obstruction. I'll call the other questions in the chat box. I think I'll call on Dr. Ozo. Oh, Dr. Maduka, your line is still bad. Dr. Ozo, if you can help us talk about the pressure recovery phenomenon and energy loss gradient in AS.
Chief, sir, I don't actually understand it very well. That was why I just brought it up.
You brought it, okay.
Yeah.
I don't also quite remember it. I know that the pressure, so the pressure recovery phenomenon and energy loss. I don't quite remember. So maybe someone else in the group can help. Anybody who remember that. And then there is also this question Dr. Barr has put. I think this low dose dobutamine stress test is for classical low flow, low gradient. Okay. And then you also say aortic calcium score using CT scans come into play when you are talking about paradoxical low flow, low gradient, and normal flow, normal gradient. Okay, so I don't know if I can just respond to that, Dr. Mba's question. So the low dose dobutamine test can be used to differentiate both. So to find out whether there is low flow, low gradient, and to see whether you have a true aortic stenosis or it is a low flow that is giving you a severe aortic stenosis. So when you look at, I think it's the ESC guideline, the algorithm. So when you get a patient, you do planimetry, it's showing you a severe aortic stenosis, but then you measure the gradient across, the gradient is low, okay, and the ejection fraction is also low. Now you want to find out whether this is a low flow, low gradient ejection fraction, or is a pseudo severe aortic stenosis because of the low pressure. So you do your dobutamine test. So when you do the dobutamine test, okay, if the pressure gradient now increase when you do the dobutamine test, the pressure gradient increase, okay, to the values of a severe aortic stenosis, then you make a diagnosis of a low flow, low gradient aortic stenosis, okay? And those patients actually need aortic valve replacement, because if you do the aortic valve replacement, it improves LV function and also the EF can improve, okay? Whereas if when you give the dobutamine, what looked like a severe aortic stenosis, now the gradient does not increase, but rather the valve area actually increase when you do the dobutamine, you give the low dose dobutamine, then you now make a diagnosis of a pseudo severe aortic stenosis, okay? Because increasing the ejection fraction now produces a lower gradient, and the valve area also increase. So in those patients, there is actually a problem, either a coronary artery disease problem or structural problem with the left ventricle that is reducing the EF. And if you take care of that, the patient will not have features suggestive of aortic stenosis. I hope I have tried to explain that. Yes, and then from Dr. Itubi, say low dose DSE can help distinguish between pseudo and true aortic. Yeah, okay, So that's the same point I was making. Very good. And then Dr. Neka is saying Brockenbrough-Braunwald's Moreau. Okay, there is a third name. Yeah, I'm just remembering the first two. Brockenbrough-Braunwald Moreau sign. Okay, so that's what helps you to differentiate between fixed LVOT obstruction and dynamic LVOT obstruction. All right. Is there anyone who can help us with this pressure recovery phenomenon and energy loss gradient in aortic stenosis? I think we would have to turn over to our chiefs to help us. Dr. Okopi, please, I'll hand over the floor to you to take comments from our chiefs, and then if you're able to help us with this question posed by Dr. Ozo. Thank you very much.
Thank you so much, Dr. Conte, for that excellent coordination. I think it was, I don't know, all through the time that Dr. Korafor, also please, thank you. Very beautiful presentation. Thank you for the sacrifice to make the slides available. Also, thank you, Dr. Alex, for making it available to him too. All through the time he was presenting, I wasn't hearing anything, but when he stopped, everybody's talking. I was just hearing, so I don't know. I didn't even quite follow. I was just hanging around to be sure I will get to a point. I didn't hear anything in between.
Yeah, he was going on and
so
off.
Dr. Allison, please, do you have...
when he was talking, we were able to hear during the time he was doing the presentation.
Okay. I'm so sorry. I didn't even follow through the presentation. I thought it was my network, but after you guys started speaking, it was all clear through. Let me call on Dr. Allison to make some comments.
Okay, thank you, Dr. Okopi. Good evening, everyone. Thank you.